It's my complete pleasure to introduce Dr. Shaun Watson. He is a senior neurologist who works at the Prince of Wales Hospitals and privately at Randwick and Blacktown. His particular clinical expertise is in neurotology and neurophysiology, especially around nerve conduction studies. And lots of patients with chronic or recurrent issues who've seen other specialists and therapists form the core of Dr. Watson's practice, and he gives them some expertise, consideration, and lots of compassion, and usually gets really good outcomes for them. So I'll just hand over to Dr. Watson.
Thank you very much for that lovely introduction, Andrew. Really appreciate it. I'm just on my phone because, as you've gathered, I've had some technical issues. So I just want to kind of clarify that everybody can actually see and hear me before I get started. Yeah, good.
Yep.
Fantastic.
I can see you and hear you. Yep.
Yeah, good. So I would say it's a very good thing that I elected tonight not to kind of rely on the standard PowerPoint and make things a bit more kind of up close and personal, because if I had been relying on a PowerPoint, it would have been already at this point a total and dismal failure. So instead, we'll just have a chat. We'll have a face-to-face chat from home. I just really want to talk very clinically and very simply, and I hope in a way that you guys can easily access, about something that you already know a lot about, but perhaps there will be, a few little new points that come up through the discussion. So I'm going to start by talking about Meniere's disease, but I will also touch on vestibular migraine, which is really the main differential diagnosis. But Meniere's disease, you all know. It's a fairly large part of my practice, particularly at my Blacktown rooms, where I really focus on vertigo. In fact, vertigo is in some shape or form is all I see in my Blacktown practice, but I see vertigo in the other rooms as well. So as you know, Meniere's disease has been recognised since the 19th century. In some ways, for me, it's an easy diagnosis, but a terribly important diagnosis. And there are many cases where it's not so easy, and perhaps the real issue that requires experience and expertise, and hopefully also the compassion that Andrew touched upon, is when it comes to management, which I also hopefully will have time to kind of touch upon a little. But in terms of the diagnosis, it starts with just a recognition of recurrent spontaneous vertigo. So in other words, in most cases, nasty attacks of spinning vertigo, lasting half an hour to many hours, that come back. So it's not just a one-off like some other conditions, and the duration is a critical factor in separating Meniere's from a lot of other conditions, some of which are more common. And really, when it comes down to this presentation with nasty attacks of current spinning vertigo, often with vomiting, often with unsteadiness, miserable, horrible, awful attacks. There are actually only two conditions to seriously consider. And one of them, of course, is Meniere's disease, and the other is vestibular migraine. And so in that sense, the job seems kind of relatively easy, because you've got someone who's coming to you with a terrible problem, a devastating problem, a problem that's clearly having a major impact on every aspect of quality of life, triggering anxiety, and you're really only considering two main conditions if you've taken a kind of a reasonably adequate history and done a reasonably adequate initial assessment. And I guess the thing that really separates the two conditions in terms of the initial assessment, the history, is whether there's any involvement of the ears. Or what I mean by that is whether there's any clear fullness, pressure, localized to one ear in the vast majority of cases, whether there's any hearing loss, whether there's any tinnitus localized to one ear in the vast majority of cases. And the diagnosis, I guess, in a sense, from my perspective, becomes relatively easy if fluctuation and change in those ear hearing related symptoms coincide in some way with the vertigo attacks. And if you've got that constellation, so the recurrent spontaneous vertigo, so multiple nasty vertigo attacks, time locked in some way to kind of ear and hearing symptoms, then you pretty much have Meniere's disease. And then the job from there is to confirm it and treat it. Now, I will just touch on vestibular migraine, because I guess historically, not so much nowadays, but perhaps even nowadays, historically, vestibular migraine wasn't often recognised, and perhaps certainly even early in my career, Meniere's disease was sometimes overdiagnosed, vestibular migraine was sometimes underdiagnosed, and I guess probably in certain places with perhaps a little bit less expertise than Sydney and Melbourne, that can still occur. So the real, I guess, the essence, the clinical essence, is that vestibular migraine, usually there's a background of other migraine, which I won't go into in detail. Often there are associated migrainous symptoms at the time, although I should add that migrainous symptoms can also occur with Meniere's disease attacks. That's well recognised, and I see that quite frequently too. But most importantly of all, vestibular migraine attacks, which can be quite similar to Meniere's attacks, although not usually as severe, and a little bit more variable in terms of the time course and in terms of the nature of the vertigo. But the essence of separating Meniere's disease from vestibular migraine is that vestibular migraine almost never has such clear unilateral ear and hearing symptoms of the type that you're probably all familiar with and I've already touched upon. But there are certainly, I mean, I saw someone as recently as yesterday who described very frequent, horrible attacks of vertigo that would certainly fit best with Meniere's disease, and absolutely no symptoms. And this has been going on in her case since the beginning of the year, so for almost 6 months, but no symptoms at all referable to her ears, directly referable to her ears. So none of the fullness, none of the pressure, none of the tinnitus, none of the hearing loss. And so, and also a distant background of migraine, but no kind of recent migraine and no kind of, compelling features for vestibular migraine. So these are the kind of cases, this is the kind of situation which is not so uncommon, where testing becomes particularly important. Now, frankly, I think fairly comprehensive hearing imbalance type testing is important for pretty much all patients with Meniere's disease. Now, if we were kind of practicing on a desert island somewhere with access to only one investigation, so only one test, then that would be some form of audiometry. So even though as a neurologist, neurotologist, I'm in some ways more interested in the vertigo and more interested in the kind of vestibular function test, and that's, I guess, one of my areas of expertise is all kind of the increasing array of vestibular function tests. I recognise, and I think it is generally recognised, that if you had one test, it would be audiometry. And this particular patient had very, very slight asymmetry of hearing testing just at the bedside, in my rooms. But when she had formal audiometry, it shows that the classic low frequency hearing loss, which I would have liked to show you, but I think it might be just a bit messy with the phone presentation. But you've probably seen audiograms, kind of the graphs, what they look like. The classic thing we see in Meniere's disease is that the low frequency end, so the left side of the graph is low on one side, and sometimes we see it right across the whole graph. But it's kind of opposite to what you see with kind of age-related hearing loss, which is kind of high frequency. So you see a drop on the right side of the graph. So if we had the one test, it would be audiometry. But then we've got all these other kind of wonderful, sophisticated tests that we use, and also have a lot of benefit in terms of really clarifying the diagnosis, and in some cases kind of following patients and following progress. Now, I don't want to go into those tests in too much detail, but the good old-fashioned caloric test, which if you guys I assume that most of you are Meniere's disease sufferers will almost certainly have had at some stage. So that's the test where we kind of run. So here's I don't know if you can see this. I don't think I'm going to try and play around with the phone too much. I have a model of the ear, which I was going to kind of use to demonstrate a few things, but I think I'll just talk, and you can kind of put up with my voice and my face, and I'll try and do the best I can to explain without images and models. But basically the caloric test is running warm or cool water through the external canal, so into the ear, which then kind of sets up a kind of a temperature gradient within the inner ear, and it's obviously the inner ear which is important in terms of Meniere's disease. And makes you, in most cases, dizzy, and in some cases, it feels almost as though you're having an attack, because it can cause, in some patients, quite severe vertigo. And you can kind of compare the two sides. You can compare left to right, and you can compare the warm response and the cool response on each side, and do calculations and work out where there's a difference between the two sides. And that's a test that's been around for a really long time. And that developing the caloric test actually won a Hungarian neurologist, Robert Barani, the Nobel Prize in 1915. So it's a kind of really, really important development in medicine. And still, it is the most sensitive and the most useful test for detecting Meniere's disease in 2021. And there have been quite a lot of papers, quite a lot of studies done. I've done one myself, which show that the caloric test is the most sensitive for picking up vestibular, balance-related abnormalities in Meniere's disease. And really interestingly, some of the newer tests, some of them have been developed here in Sydney, which look more directly at the kind of the vestibular hair cell function, are actually often normal, which is kind of a really interesting observation, because it kind of goes quite strongly against the idea of Meniere's disease kind of burning out, which is something I'm sure you guys have all kind of heard about, because even people have had Meniere's disease for 20 years, 30 years, the caloric test is often abnormal, but these other tests that actually look at those little delicate hair cells in the inner ear directly are often normal, suggesting that the actual nerve function of the inner ear, or at least the vestibular balance vertigo part of the inner ear, is still intact. Other tests that we do, most patients, because it's 2021 and we live in a rich country with a sophisticated healthcare system, most patients end up having an MRI scan to kind of rule out things. But in the vast majority of cases, the MRI scan doesn't actually reveal any abnormality in Meniere's disease, just to rule out tumours and stuff like that. Although there is a new MRI scan kind of protocol, which is just starting to creep into Australia, which is quite well established, particularly in Europe, where you have a dye injection and then you have the MRI scan of the ear 3 or 4 hours later, and it can actually show, it was the one slide I actually did want to show, it can actually show the swelling of the inner ear. It can actually directly demonstrate the engorgement and swelling of the inner ear kind of fluid system, which is the basic pathophysiology, so the basic underlying cause of Meniere's disease. That's something I only do relatively rarely, although it is available in Sydney, because it's reasonably unpleasant, it's reasonably expensive, and in most cases it doesn't kind of add much, because if you kind of on the more basic assessment know what you're dealing with, you're dealing with Meniere's disease. In 2021, you can keep on doing tests till the cows come home, but at some point, enough is enough, and certainly, you can have enough information to guide treatment way before you get to an MRI scan. So, and I might add that really all of those tests, all of the hearing test, all of the balance tests, the perfusion and balance tests that we do as part of a routine protocol, or sort of like a more sophisticated kind of research-based protocol. All of them should be normal in vestibular migraine. Occasionally, they're all normal in Meniere's disease too, and that's where it becomes, again, where it becomes tricky and where you have to reconsider, are you on the right track? Is it the right diagnosis? Is Meniere's disease the right diagnosis? You have to reconsider, and sometimes that's just a matter of repeating the hearing test a few times. Sometimes it's a matter of repeating the other tests. And very occasionally, the diagnosis is only made on this new MRI scan protocol, which I've referred to. I think that's, I've had one patient with Meniere's disease who falls into that category, and there is still a role for electrocochleography, although which is basically passing a little recording needle through the eardrum and recording the electrical activity of the inner ear directly. But that's not something that I do very often at all anymore, because the other tests are less painful, less invasive, easier to interpret in a lot of cases. So testing for me is audiometry, hearing test number one, and caloric testing and a few other fairly standard vestibular function tests number two, MRI scan just to rule out nasty stuff, and occasionally the flash new special MRI scan if you're really in doubt. And then you want to kind of obviously get down to treatment. I still see people today, and I'm sure that there must be some amongst you who have had this kind of experience in the past, who see not just a GP but a neurologist or an ENT surgeon who makes the diagnosis of Meniere's disease, and perhaps in a fairly kind of I guess perfunctory manner, a fairly kind of rapid manner, and kind of implies or even states emphatically that there is no treatment and there is nothing to be done, and one day will burn out, implying that you've got to put up with these horrible attacks until it just of its own accord, sometime down the track, some number of years down the track, cures itself. Now, I mean, my view certainly is that every patient with Meniere's disease needs some form of treatment, and my strong view is that the vertigo attacks can almost always be controlled if you try hard enough. Unfortunately, the auditory side of things, so the hearing loss and the tinnitus, is in my experience, and I think it's general experience, more difficult to manage and control. But I think for probably the majority of people with Meniere's disease, it's the recurring horrible vertigo attacks that are really the number one life-destroying issue. And I've had patients say to me, I'd rather die than have another attack like that, referring to a particularly severe vertigo attack. And also, many patients describing that the very, very worst thing they've ever experienced in their life is a bad attack of Meniere's disease, particularly if associated with being flung to the ground in a drop attack. So what do I do? I mean, I guess so the underlying cause is the kind of the swelling of the endolymph, which is the kind of the innermost fluid-filled sac, which is kind of elaborated within the labyrinth. And so it kind of makes sense that you want to try and reduce the fluid pressure, reduce the fluid volume in the inner ear. And indeed, the way to attempt that is salt restriction, which I'm sure you're all familiar with. Anyone who has anything to do with Meniere's disease is familiar with salt restriction. And I quite like my salt as a non-Meniere's disease sufferer, and I often think how difficult it would be to. So again, we sometimes make these recommendations fairly glibly, but I think it speaks to just how unpleasant the attacks of Meniere's disease can be, that most of my patients seem to adopt salt restriction kind of willingly and with some degree of enthusiasm. There are exceptions, of course, but and I must say that there's a significant proportion of people who stop having attacks if they just cut out salt. Other dietary factors are a little bit more variable between patients and a little bit more controversial. And I kind of take the view that you can't just kind of, particularly at the first meeting of a patient with Meniere's disease, or perhaps even kind of early on, you can't just say, cut out this, and give them some kind of long list. I generally start with salt, and people, there are certainly people who find that caffeine and alcohol and other dietary factors are relevant, but there are others who can do just fine keeping those things on board. And interestingly, there are also patients for whom salt seems to make no difference whatsoever, and other people who seem to be exquisitely sensitive to salt, and some people who only have attacks if they have some kind of, fish and chips style dietary indiscretion, and other people who just have attacks that seem to bear no relationship whatsoever to diet and salt at all. So again, Meniere's disease sufferers, patients, have a lot in common, but each of you is an individual with individual, even just relating to the Meniere's disease itself, considerable variation from person to person in terms of how the attacks play out and how they're triggered. Stress is sometimes seems to be and is reported to be a triggering factor, and certainly I have some patients where it's clearly the major triggering factor. So that can be managed in various ways, which I won't go into all the details of that here. Beyond that, I don't want to go. I feel like I'm kind of running close to time, because even though we start a little bit late, I want there to be time for questions. I don't want to just be a kind of a talking head all night. I definitely find that beta histine, so commonly known as SERC, is beneficial for a significant proportion of patients, and sometimes miraculously beneficial. There's not a huge amount of scientific evidence backing it up, but I have no doubt from my experience, and backed up by certain German studies as well, that it can be beneficial, and I use it early and frequently, and sometimes at very high doses. So there's no upper limit, in fact, to the dose that I would use in certain patients, and it's more restricted by cost in Australia than it is by safety, because it's an incredibly safe medication. And how long you continue taking it, there's no answer to that question. How long is a piece of string? It just varies from situation to situation. The other medication where I should have touched on earlier is diuretics. Definitely have a role. So in other words, that's kind of augmenting the salt restriction using a medication that passes salt and water through the kidneys, and they sometimes work very well. And then beyond SERC, if SERC doesn't work, I often move to a medication that many of you will be familiar with called Stugeron or Sinarazine. Again, there's not a huge amount of scientific evidence for it, but I have had so many spectacular successes with Stugeron. that I will certainly always continue to use it. And then if all of those things fail, which they rarely do, the vast majority of patients, well, let's say at least 90% and probably 95% respond to something relatively simple. So dietary restriction or relatively simple and safe medications, as I referred to above. Then you're kind of moving into the territory where, so up to that point, I'm very happy to do it all. I'm a neurologist, I'm not an ENT surgeon. I don't perform operations, I don't perform procedures. I'm mainly a diagnostician and mainly managing through kind of non-invasive, non-intervention, non-surgical approaches. But beyond that, I would always get a kind of a keen and enthusiastic ENT surgeon involved. And, you know, not all neurologists are alike. There are some neurologists who know next to nothing about vertigo, and there are some ENT surgeons who are not really interested in vertigo and not interested in Meniere's disease, and others who are equally, if not more, enthusiastic than me in managing Meniere's disease. And I'm sure, I would hope that many of you have met such ENT surgeons. And then we move on to kind of the next phase, which would be kind of injection treatment through the eardrum into the middle ear and then seeping through to the inner ear. And that would either be steroid injections, which can be dramatically beneficial, or gentamicin injections, which are almost always successful. There are rare exceptions just because of anatomy issues with the ear, but it is basically you're kind of moving there then into kind of like an ablation procedure. You're basically destroying the hair cells of the vestibular system to abolish the capacity of the inner ear to cause vertigo attacks. But the problem with that, of course, is that a proportion of patients will develop chronic balance problems because they've lost the balance function in one ear. Fortunately, it's not a large proportion, but it's a little bit debatable about what proportion. But I generally quote somewhere around 1 in 10, and that's that. You know, so that's a significant consideration. And then beyond that, we're talking about various operations up to and including cutting out the whole labyrinth, which will definitively, if it's done well, abolish vertigo attacks, but also obviously leaves you with loss of hearing in that ear. So if you need to, and you push hard enough, you know, following, I suppose, a ladder from the simplest, lowest rung of the ladder being the kind of the simplest and safest treatment, which is just kind of dietary and understanding and looking for triggering factors, up to injection style therapy, you can control 99% of patients' vertigo attacks. And I can't even think of the last time that I've sent a patient to have a major ear operation, because we can get by with simpler therapy. So, and just one last word. I know there's some questions coming in, which I think Anne will kind of direct to me in a tick. I've kind of, to some extent, dismissed the idea of burnout. You know, the hope, the old-fashioned hope being that if you just kind of wait long enough, the ear will just become some little kind of scarred crisp, and it won't be possible to, almost like a sort of auto gentamicin injection into the ear to stop the attacks. I'm not wanting to take away people's hope when I partly dismiss that notion, because I think what I see in practice and what we all see in practice, and hopefully what many of you have experienced, is that even though the ear mightn't kind of burn out, many patients do go into remission. So many patients, even though they still have inner ear nerve function and hair cell function, do go into remission. So, I think for anyone with Meniere's disease, there's a huge amount of hope. I think anyone who suggests that the situation is hopeless or takes a kind of a strong nihilistic view about Meniere's disease and the outcome is not doing you guys a service. So through working hard on treatment, but also just recognising that people do just get better. I think it's an area where people suffer miserably at times, but there is a huge amount of hope for better times down the track. And I said I wouldn't say anything else, but I feel I should just comment briefly on bilateral Meniere's disease, because that's obviously a great fear of a lot of patients. Mm-hmm. And again, that is relatively rare. Different studies quote different figures. My own experience, my own practice is that severe bilateral Meniere's disease is incredibly rare. A little bit of involvement of the other ear is rare, and the vast majority of patients have strictly or almost completely unilateral Meniere's disease. I won't quote figures, but that's my experience. So I'm going to close up at that point and hopefully just answer a few questions.
Okay, thanks, Shaun. That's fine.
Oh my goodness. The first question was your question, Anne, and I'm not sure that Shaun didn't answer it, did he?
Read it.
It was ongoing 24/7 dizziness. Is this Meniere's or some other disease?
Oh no, I didn't answer that, and that's a really good question. It's a great question. It's a hard question to answer. I would say that in many cases, it is a secondary process rather than the Meniere's disease, or rather than the hydrops, rather than the kind of the fluid balance abnormality itself. But I'm sure that there are a small number of patients who have kind of low grade, kind of grumbling Meniere's disease that directly causes 24/7 dizziness. But I guess I started talking about Meniere's disease and vestibular migraine. I could talk all night about vestibular migraine. I guess I could talk all night about Meniere's disease too. But vestibular migraine is such a kind of complicated and controversial area. But migraine is more common in Meniere's disease sufferers, and active Meniere's disease does seem to trigger migraine headache and vestibular migraine in some patients, and does certainly contribute to chronic low-grade vertigo in some Meniere's disease sufferers. There's also a condition that I'm sure many of you, perhaps if not all of you, have come across, called triple PD, which is a little bit of a hard one to get your head around, and I'm always trying to kind of think of new ways of describing it and explaining it to patients, because I guess so. It's triple PD is a relatively new diagnosis in terms of the actual name, but the kind of the idea of it's been around for a long time, and it's essentially persistent postural perceptual dizziness, and it's more often the kind of rather than constant spinning, it's more of a kind of rocking, kind of swaying dizziness, which is often related to kind of posture and movement. And I think the people who understand it best and the people who've studied it most don't talk about it as being anxiety, because I mean sometimes it is equated with anxiety, but it's more a kind of a hypersensitivity of the vestibular system, of the kind of the vestibular system, the balance system in the brain rather than in the ear, which is set off by the ear problem, and so is almost like a direct consequence of the ear problem. And so it's almost a little bit like, again, I don't want to describe it as anxiety, because I think that puts people off, and I also think it's misleading. It's almost a little bit like a kind of a memory of vertigo becomes ingrained. It's like a scratched record, or it's a little bit like the equivalent of kind of post-traumatic stress disorder. So it's like the experience of vertigo caused by the Meniere's disease leads to this secondary hypersensitivity and tendency to over-awareness of head motion and visual motion that develops within the brain, which is also, and it's important to kind of recognize the possibility. It can sometimes be a little bit confronting for patients, I think, but it's important to recognize the possibility, because it does open up a different kind of treatment perspective to what I've just talked about for kind of pure, clear, classic Meniere's disease. And it certainly opens up a perspective that includes vestibular physiotherapy, that includes, psychology with some expertise in vestibular management, and also sometimes includes kind of migraine medications if you feel it's a migraine process, or sometimes antidepressants and anti-anxiety medications if you feel that it's this triple PD is the predominant problem. And I want to say there that even though I'm talking about using antidepressants and anti-anxiety medications, we use these kind of medications for lots of things, and it doesn't mean that the problem is psychological, or it's purely psychological. In my view, it's physiological. But then, I think the modern understanding in the brain is that the physiological and the psychological, so the physical and the psychological, are kind of two sides of one coin to some extent, or at least influence one another and are often inseparable in practice. So that's a very long-winded answer, because it's such an interesting question and such an important question, but I hope that gives a little bit of clarification.
That's fantastic. Thank you. Being aware that there's probably 15 questions here.
Yeah.
I'm going to attempt to save them all.
Yep.
Question 2 is, can you talk about burnout?
I think I have talked about burnout. So I'm going to be very, very quick and say that I'm sure that it does occur, but I think it's relatively rare. And I think that modern vestibular function tests have shown that vestibular, but now it might be that you can have burnout of hearing, which doesn't really do you much good, but vestibular burnout, stopping attacks, is probably not the cause of remission in the vast majority of cases. And we don't really understand why people go into remission, but they do. So you don't have to wait for burnout, just wait for remission. But also in the meantime, actively manage and control the vertigo attacks using the kind of approach I talked about before.
What is the difference? Thank you. What is the difference between being treated and managed by an ENT over a neurologist, or for an MD patient, or should an MD patient see both?
I think that what's important is not whether you see a neurologist or an ENT surgeon, but whether you see someone who is passionate about managing Meniere's disease and is kind of open to a kind of a flexible and individual approach that encompasses all of the kind of the treatment modalities that I've referred to before. I'm as a neurologist who specializes in vertigo, I don't feel that all of my patients also need to see an ENT surgeon. And I would involve an ENT surgeon mainly if a procedure was involved. But I know lots of fantastic ENT surgeons who would manage all of the earlier stages of treatment just as well as I would. And so there's no reason why everyone needs to see both. There's, you know, if you're struggling with treatment, if you're struggling with your specialist, then perhaps it's worth trying someone from the opposite side. I mean, I say that we're not enemies, and we're good mates, and we're all kind of working together with the same patients. But if you're not doing well with an ENT surgeon, try a neurologist. If you're not doing well with a neurologist, try an ENT surgeon. But either way, depending on where you live and your circumstances, try and find someone who's passionate about Meniere's disease and passionate about vertigo in general, because there's a huge range in both camps. What's more important is finding someone who's passionate and expert rather than, neurologist versus ENT. But certainly I would the one thing I would say is I would definitely advocate, reasonably aggressive medical treatment before actually doing anything that could kind of cause permanent damage to the ear by way of kind of surgery or injection. But then most ENT surgeons would take the same view.
Thank you. This person talks about their mum, and their request is, what's the relationship between the sinuses and Meniere's disease? Yeah.
Look, that's a great question too. And I've talked about hydrops. Hydrops is the basic process that causes Meniere's disease in most cases, if not all cases. So they're kind of the engorgement. But what causes the hydrops is the million-dollar question, really. In some cases, it seems to be totally just out of the blue kind of condition. In some cases, there are genetic components. In some cases, there are allergic components. In some cases, it does appear to be related to kind of prior ear injury or kind of long-standing hearing loss in one ear can cause kind of a very similar condition. And in some cases, it really seems to be related to migraine too. Migraine seems to be the root cause of Meniere's disease in some cases, without doubt, in my opinion. Sinuses probably too. I wouldn't put sinuses high on the list, but I would say that in other words, I think Meniere's disease has a pathophysiology, which is the kind of fluid engorgement, the fluid overload of the kind of the endolymph, which is at the core of the fluid system in the inner ear. And there's a whole lot of different things that could potentially kind of feed into that. And I guess you just kind of treat what is treatable depending on the patient's individual circumstances. And I obviously can't say more than that in relation to your mother.
Drop attacks. Can you explain what happens when they occur?
Yeah, I'm not entirely sure. I mean, what they are is, thankfully they're relatively uncommon. It's a relatively small proportion of people with Meniere's disease attacks who get them. So it's basically being thrown to the ground or dropping to the ground as part of an attack, which can occur with a typical vertigo attack or can occur kind of separately as a completely separate phenomenon. Now, in terms of the actual attacks of vertigo, we don't quite know what causes the attacks of vertigo in any case, but it's thought that it's not the engorgement, it's not the actual swelling, it's probably like an internal rupture of a membrane that causes the vertigo attacks. And some patients, it's not that uncommon. It's almost like the classic textbook thing is that with a typical Meniere's disease attack, there's a build-up of tinnitus, there's a build-up of pressure, there's a drop of hearing, then there's the vertigo attack, and sometimes the hearing actually seems to improve at least in some patients, after the attack. So it suggests there's something really funny and complicated going on at least in some of these of the vertigo attacks with Meniere's disease. And I'm assuming that something somewhat similar happens with the drop attacks. That, you know, they're the most kind of, I mean, the most sudden and dramatic manifestation of Meniere's disease. And I think probably there's some kind of tearing of a membrane somewhere separating the different fluid compartments that causes the drop attacks. But, you know, people are getting a lot of drop attacks. That's when you have to start getting pretty aggressive with treatment. It doesn't always mean injections or surgery. I've treated plenty of patients with drop attacks successfully with the kind of medications I've alluded to. So I can't give you a really clear answer as to what is the cause, because I don't think anyone really knows.
Thank you.
Yeah.
So, and how much time have we got now?
Just do one more question, perhaps.
Well, the next one was regarding sodium and low sodium doses.
Yes.
Whether there's any more you would like to say about that, recommending what's safe.
Look, there are guidelines. There are, you know, you can do a 24-hour urinary sodium and kind of check the kind of the millimole level, and that is valid in some patients. But again, I tend to take a little bit more of a flexible kind of individual approach. I'm not bagging or dismissing that kind of very rigorous kind of approach, but some patients find that just avoiding indiscretions, you know, junk, high salt type indiscretions is enough. Some patients find that just kind of being mindful of salt and kind of avoiding adding salt and avoiding kind of highly salty foods is enough. Some patients find that they have to kind of really check the sodium on everything they eat and basically avoid anything that is kind of medium to high sodium. And some patients need to kind of go through, you know, salt skip programs or see dietitians and kind of aim for ultra low sodiums. If I once we get into that territory, I'd be also looking at adding in some other medication, just to not be so reliant just on one arm of treatment. I hope that answers the question.
Thank you. Can I pressure somebody who suffers
good
pressure?
Yeah, head pressure, and the head pressure is, I mean, there are lots of symptoms that can be associated with Meniere's attacks, and so I think there are quite a lot of kind of good studies that have shown that all of the things that we would normally associate with vestibular migraine can be associated with Meniere's attacks. And that certainly includes head pressure, headache, sensitivity to light, sensitivity to noise. Ear pressure obviously is an extremely common symptom. It's usually unilateral, but ear pressure can kind of, I guess, there's a spectrum between ear pressure and head pressure. So head pressure can be arguably directly related to Meniere's disease. It can be related to kind of intercurrent migraine. It can be related to, one thing I haven't touched on is, you know, so many people with recurrent vertigo get neck problems that can also trigger head pressure and headache and head pain. A little bit like the first question with you know, chronic dizziness, 24/7 dizziness. It really comes down to, you know, when you get away from the classic, you know, vertigo attacks associated with fluctuating unilateral hearing loss and pressure, I guess that's where you kind of get into the art of medicine and a little bit away from the science, although there is some science there too. And it's really a matter of, in a given individual, just kind of, you know, nutting out as best you can, you know, using all of the tools at your disposal, you know, what is it that you're experiencing? What is it? What, getting the history as clearly as possible. Sometimes these things are very hard to put into words and very hard to explain. Some of the sensations, some of the types of vertigo and other sensations that people get with Meniere's and other related conditions. And then kind of trying to work out, well, in this particular patient, in you, the person who's sitting in front of me, what's the most disabling, what's the most troubling symptom, or what's the group of symptoms that are most disabling and troubling, and which of them are directly related to the Meniere's disease and require kind of more aggressive treatment of that condition, and which of them are related to kind of associated problems. As I've mentioned before, the whole kind of range of different things that can occur secondary to Meniere's disease or intercurrent with Meniere's disease. So I can't be more specific about the pressure other than to say that it's I see lots and lots of things. We could talk about other symptoms. We could talk about kind of brain fog. We could talk about all these other things that people commonly experience. And I think most of them are what I would call that they're not what I'd consider to be kind of core features of Meniere's disease, but they probably can be very closely related to Meniere's disease. But I guess the job of a neurologist or ENT surgeon looking after an individual patient is to take the broadest possible view and hopefully find some kind of treatable cause, whether that's Meniere's disease or some other factor. I think that's probably a good point to end on. Because it kind of really emphasize, I guess I started out kind of talking about the typical the typical diagnosis and the kind of the typical treatment path. And increasingly with some of these questions, we're kind of touching on exploring just the complexity of the lived experience of patients with Meniere's disease and other vertigo conditions, and where the art of medicine overlaps with the complexity of the lived experience of the individual patient. I find that the most challenging, interesting and rewarding part of my practice. Even though some people might find it the most frustrating, I actually find it the most rewarding, because that's what clinical medicine is really about, is trying to nut out these difficult problems, because these problems are not straightforward, and I can't give you a simple, straightforward answer to any of these questions.
Everyone's different, right?
Everyone's different, absolutely. Everyone's different.
Okay.
You got it. And so it's the doctor's job, the specialist's job, to recognise that and to kind of search for an individual solution or an individual series of solutions. It may not be one solution.
Okay. So what do you reckon? Do we shut up now? Close up?
I reckon we should. Yeah. And I apologise for being late, and I apologise for being technically incompetent. And I hope this little just this mobile phone kind of at home on a Wednesday evening has been satisfactory. But I've certainly enjoyed it, and good luck to you all.